Thank you all for joining us. I'm Patti Davis, President of the Oklahoma Hospital Association, and the purpose of this session is literally to provide information to the public regarding what's going on with COVID-19 in Oklahoma. Joining me today are Kris, who is the president of OU Medical Center, and Jonas Rabel, who is the chief hospital executive of the Miami Grove and the Miami INTEGRIS hospitals in Oklahoma. We have chosen them wisely because both of these individuals are presidents of their hospital, but they also started in the ranks of hospital nursing as RNs at the bedside. So they have seen both sides of hospital operations. Now, in full disclosure, none of us are wearing masks because we are all in the privacy of our own space. And I can assure you that Kris Gose is truly not at the base of a beautiful waterfall. So with that, let's get started. So Kris, tell us just a little bit about yourself.
Hi, Patti. Thanks for the opportunity to be here today. I started my career in 1995 with dual degrees from OU in both nursing and business, as Patti referred to, and started working as a pediatric nurse at the Children's Hospital of Oklahoma. Spent time at the bedside and then 15 years in nursing leadership in different roles across what would now be the OU medicine system as an educator, manager, director, and the privilege of being the system chief nursing officer for about 7 years. And then for the last 7 years have been the president of OU Medical Center, getting to bring all of our disciplines together and enjoy leading healthcare in this way and bringing all the story together.
Jonas, let's hear your story.
Yeah, I'm Jonas Rabel. I'm married with 3 kids. I graduated nursing school in 2004. I've worked as a med-surg nurse, ICU nurse, CVICU nurse, time in the ER as well. I've been a nursing director, a chief nursing officer, and a president of, as you mentioned, INTEGRIS Miami and INTEGRIS Grove hospitals. And so enjoyed my time as a nurse, and I've enjoyed all the stops along the way.
Well, and thank you for joining us. As I said earlier, where we find ourselves are today, there are a lot of discussions going on with what's going on in Oklahoma as it relates to the hospital surge plan. And we see a number of questions that get asked on social media and also by members of the press about what is the situation at Oklahoma hospitals. So the questions I'm going to ask you are clearly directed at what's going on in your particular hospital. But first, let me just explain. A surge plan is something that we were asked to put together by the governor to prepare Oklahoma's hospitals should we see excessive demands created because of COVID spread. And it's a thoughtful plan developed by region to assess the resources that are available in the region and to understand how many hospital beds are available, how many ICU beds are available, ventilators, and then likewise what numbers of staff we would need to surge up to an increased demand, as well as personal protective equipment. So for you, Kris, what does normal capacity look like at OU Medicine on a day-to-day basis?
Well, Patti, I know that you are just north of us, so I know that you have seen the new patient tower up in the sky. And so even pre-COVID, this OU Medical Center had challenges on a daily basis, but was part of our normal routine that we operated at 95 to 105% occupied. Our normal day consists of 20 to 100 discharges of patients that get to go home or to another setting, and with the same number of admits or more. And that keeps us fully functioning at close to our bed capability. So we're rather used to having to find flexible beds that aren't what you would picture as a normal walking into a hospital room. so that we may temporarily have to use those on a daily basis, what would be considered a recovery room as a temporary bed for a patient, which has become obviously very critical to understand and utilize in this time period. But normally, our license capability is 367, and we're operating all of those on a daily basis at greater than 90%.
Well, and Jonas, for you, you're operating 2 hospitals up in the Grand Lake area, and it's summertime, and you have increased tourism trades and certainly more potential for accidents. So what does it look like for your hospitals this summer?
Yeah, so I would say it's a little bit different than Chris's situation. Our licensed beds versus our staff beds is a little bit different. Our staffing, we don't quite staff to 100% of our license capability. Our volume is a little bit lower. We do have peaks and valleys. Patti, as you mentioned, in the summertime, Grand Lake is a major destination area, so we get people from all over, from Oklahoma City, Tulsa, Kansas City, Wichita, that come to the lake. Typically for the weekends in the summertime. However, this summer it's been a little bit different. People are working more remotely, and so a lot of that volume has actually stayed at the lake this entire summer.
So you mentioned that your licensed bed number is different than your staffed bed number. Would you explain that briefly?
Yeah, so we're licensed, which means we're able to have that many beds. We don't run at 100% capacity at all times. A lot of times we're at around 50%, and so we staff to that. We look at our historic numbers. We look at trends in our volumes, and we flex accordingly.
So if in your area you had significant outbreak of COVID and you had a lot of patients needing hospital beds, would you describe your surge plan in your area?
Yeah, so what the governor asked for was for us to plan for a 40% surge, and so with us having the additional beds, we have places to put the patients, but we don't necessarily have the staff to take care of those patients. And so a surge for us is looking at agency options. It's looking at other hospitals in the system, if they're able to support us with staff, whether it be licensed or unlicensed, to help. And we actually have done that with some of our Oklahoma City and Metro hospitals. We've been able to send staff to them to help during the surge, and then at times when we've had somewhat of a surge or had staff out with COVID, they've been able to help staff some of our beds as well. And so a typical staffing ratio is 6 to 1, approximately 6 to 1 for a med surg nurse and 2 to 1 for an ICU nurse. And during times of surge, we may have to increase that ratio.
So, Kris, jump in here, because I know that OU Medicine has a very complex surge plan that's involved people across your campus. So talk about what that looks like for OU Medicine.
Yes, so I think, as Jonas referred to, I think it's important to know that every hospital always has a plan, some sort of surge plan to create some sort of capacity in any sort of situation, which has happened historically when a tornado happens or unfortunately, I was here when the bombing occurred. And so we have those capability to find spaces and find rooms and use emergent staffing scenarios to take care of patients for the need. However, what we were presented with in Oklahoma related to the prediction models for COVID patients at the beginning of this experience in the spring were incredibly high numbers, as Jonas referred to. And at the time, the community also, or nationwide, was trying to get enough personal protective equipment for everybody too. So it happened to not be the time that we felt like we should bring other patients in until we could safely take care of them and make sure we had personal protective equipment. So we limited other care during that time period, which allowed us to go even beyond what OU Medical Center could usually surge for a situation like a tornado or a natural occurrence or a trauma event. And we did that by counting all of our operating rooms as beds, as well as our recovery rooms, our surgery center, our outpatient prep areas, some of our procedural areas like our cath lab, which is where you go in for cardiovascular procedures, or our GI procedure area, our dialysis area. We counted a great number of those spaces. As Jonas referred to, we then went through the detail of trying to figure out how we'd make sure to have appropriate equipment for the patient population that we may be caring for. In this situation, I know each and every one of us were trying to make sure that we had enough ventilators for this patient population. And then Jonas talked a lot about the ratios of staff, and we talk about nursing ratios, and we did also develop for this time period, when you talk about very large numbers above what our normal occupancy is, it is important to know that we may staff those differently, but we're not each coming up with those on our own or in an unsafe manner. Those are all based off of national practices that have been looked at, and we back those up with other resources so that you may not have an RN for every 6 patients like Jonas was talking about, but you may have more physical therapists or technicians also at the bedside, or assistants. And Patti, you referred to our whole campus. So we were reaching out to college students across, working with all the nursing students and allied health students and medical students to find out what roles they could perform in this unique situation. As well as we put out information to some of the community that may be part-time or retired or teaching. Educators, faculty members were willing to step up and help so that they may not be doing the frontline piece, but we're helping collect medications and get tools and equipment that the registered nurses or the providers at the bedside would need to take care of patients in this situation.
Well, thank you. And let me just mention, as Jonas mentioned, his staffing ratio, clearly staffing ratios vary from hospital to hospital, and it absolutely depends upon the complexity of the patient. So no doubt patients in ICU have lower staffing ratios than patients that may be in a regular medical surgical bed that could be used for either patients that were sick or patients that are recovering from surgery.
Yeah, I mean, that's why I said approximately, because it is definitely very fluid, and as you mentioned, it is based a lot on the patient's acuity.
Well, and thank you. We know that in the early days of COVID, the lack of PPE and the lack of testing were limiting factors. We know that that's gotten better to some degree. Can you just please let us know what's going on in your facility?
Okay, I'll jump first. Okay. So yes, we actually we are tracking a dashboard on a daily basis that predicts our personal protective equipment. So in particular, masks. We look at the different types of masks that are needed in a healthcare setting, and we predict out how many days we have based on actually the highest surge numbers that we've ever seen in the prediction models. And so what was at one time a scarce resource, of course, one that we're still watching very closely and continuing to order and maintain, but we feel very confident as we go into greater than 60 days, some masks in some areas, greater than 200 days worth of supply on hand. And you talked about testing. That truly was a challenge at the beginning, the availability as well as the time that it was taking to turn around a test. We would sometimes have patients in the hospital waiting 5 to 9 days for a result, of course, treating them as a possible COVID patient during that time period and keeping everybody safe. That obviously utilized a lot of equipment and protection equipment during that time period for patients that potentially ended up being negative while we waited for those tests. But now we have different platforms, different tests that we can run depending on your situation. And so we can get a test back in as short as a couple of hours, and a long turnaround is usually 24 to 48 hours for our patients. We were only testing those with symptoms at the beginning of this situation because of the limited testing capability. We now test all patients that are potentially going to have a procedure and all patients upon admission. And we also have testing sites for any of those who think they have symptoms that are within our care system. So I'll hand it over to Jonas with that.
Well, that was pretty much the exact answer that I would give. We're monitoring our PPE on an ongoing basis, and so we feel that at this time we're in pretty good shape. I mean, we're definitely keeping a close eye on that, and the testing. The testing was definitely a challenge in the first couple months, and as new platforms have come online, we're doing the same thing. We're testing all of our OBs, all of our surgeries, all of our inpatients, that come in. Anyone with symptoms that comes into the ER, and just watching that. And we're keeping a log of all of those, tracking our turnaround times, and if there's any outliers, we are definitely addressing those.
So, Kris, do you have something else you'd like to add?
Well, Jonas mentioned that it was very similar, and that is not by accident. I mean, part of it is science that I think healthcare is striving for across the nation. But in Oklahoma, I think I would like for everybody to feel really confident and safe that as leaders across the hospitals and facilitated by groups like OHA, we have really worked to communicate together and work together to maximize our resources and be consistent in our practices so that every Oklahoman could know that they would get safe care wherever they were going, and that we would support each other to do that.
Well, Kris, thanks for those kind words, because clearly in my tenure at OHA, I've never seen a time when hospital leaders have been more collaborative, and it's keeping the patient at the center of those discussions. And the reason that our search plan is based on regions is we want to keep people close to home when possible. We want to make sure that the regional hospitals are supported with what they need before thinking about having to move into the metropolitan area for care if it's not necessary. So here's the time where I turn to you and say, if you had your desire in terms of imparting a message to the public or the media, what would it be regarding COVID-19?
I would say that this is an unprecedented worldwide pandemic, something that we have never truly seen before or experienced, and it's an all hands on deck effort to help with this. Everyone needs to do their part. Whether it be through wearing a mask in public, social distancing, disinfecting your hands, wiping down surfaces, that you're around. We really have to try to limit the spread of this virus, as much as possible.
Kris?
Once again, I probably no surprise, I'd mimic a lot of what Jonas had to say, and but I would also share that historically nursing has ended up as one of the most trusted professions. It's kind of disheartening to see during this time period some of the lack of faith in various different entities that I think we historically have looked to for guidance that you see in the public. But to remember that there was a reason why they looked to healthcare professionals as trusted individuals. It's our goal. We may not know everything today. The science changes as we learn about this disease because we didn't have it present in our community a year ago. That is not us trying to trick anybody. It is meant to try to keep updated information out. And what we know now is what Jonas said, is that wearing a mask and keeping distance doesn't mean we all have to hide at home. Does mean that we have to be safe and smart. And since he covered a lot of those pieces, I will also say we did see some people hiding at home early in this, and we think we need to get a very strong message out to you that if you are in pain or you are hurting, hospitals and healthcare are still here for you. We have safe environments, and we want you to come see us. But yes, make good choices.
Do not neglect getting your needs taken care of. I mean, that's it's very important because just because we have a pandemic going on does not mean you hide out in your house, and you have to take care of yourself.
Well, thank you. And I would just say parting words that we're all in this together.
Yeah.
And clearly, if everyone does their part personally to contain the spread of this by doing this, the scientific, smart information that we have today, then we know that will help not overrun the healthcare system that exists in Oklahoma today. I'd like to thank you both as being experts in this area, but also leaders in healthcare. And we very much appreciate your willingness to talk to us today. So, Kris, Gose, Jonas, Rabel, so good to have you today. Thank you.